All, this is Dr. Mobeen Sayed from drbeen.com. Welcome to one more show. So the discussion that we did yesterday about the Yale LISTEN study and the preprint study, which is a part of that bigger study, where they showed the immune system profile of vaccine injured patients or post-vaccine syndrome patients. I think they even compared them to infected versus non-infected, etc. So some of the messages that I got afterwards were that, fine, we understand this is a problem. What do we do about it? And that was my own curiosity as well, that with this immune profile, what are the things that need to be done? So what I did was I wrote a Substack article, and I wanted to go over that article with you. The reason I don't want to draw separately is that article is present on Substack. You can actually go and review it afterwards and use it as well. So let's start this discussion. So I'm going to share my screen. So this is drbeen.com. If you would like to earn CMEs or CEs, you can get access to drbeen.com. And there are a lot of good lectures by me and my colleagues. This is a study we're talking about immunological and antigenic signatures associated with chronic illness after COVID-19 vaccine. So I have gone over this. I'll put that link on this video as well. However, please remember, a live video takes up to 24 hours for YouTube to make it editable. So I'll add that link by tomorrow. So here is the protocol that I wrote. This is not an exhaustive protocol. There are so many kinds of problems that occur with the vaccine injury or long COVID. So it is not all encompassing, but I believe it is a very good start for those with this specific immune profile that you saw with the Yale University. So this is the study that is here on the Substack page. Then the management approach. What this article is about the management approach. The medical disclaimer that, of course, this is not something to self-medicate with, but this is mostly for the clinicians to understand their patient and understand how to manage them. And for clinicians, I have a message that for these strategies, start with the herbal lifestyle supplement changes first. And LDN should be started, low dose naltrexone should be started as soon as possible. And a short course of steroids will help unmask if there is an organ damage that has occurred permanently, or if it is inflammation that is causing the symptoms. Think about it. For the general public now, doctors understand what I just said. For the doctors, nurses, and PAs, the providers, the idea is this, that if vaccine injury, the symptoms are because there is continuous inflammation and the dysregulated immune system, then steroids would suppress this immune system for a week or 2 weeks, slightly suppress that, which will then remove this dysregulated immune system's behavior from the scene, and the person would feel better. If that is the case, that means hopefully there is no permanent tissue damage. If there was damage, imagine if my pancreas had become destroyed or my heart had become damaged, then removing the inflammatory aspect will not remove all the symptoms, and some symptoms would still be there, and they may be because of the tissue damage. So short-term steroid course is actually diagnostic as well, in addition to healing or helpful. So here is the summary of the picture. So what was the picture in that study? I have done the video, which I have linked here. That is a video which I did before this one. But generally, the picture was the following. On the B cells, there were unswitched B cells that were continuing to produce a specific antibody, I believe IgM, and just continuing to do that without switching to IgG or E or A. Then there were reduced double negative B cells. So D and B cells were reduced. Usually D and B cells are increased in chronic inflammation, but in this picture, there is chronic inflammation and also reduced D and B cells. So we'll have to figure out how do we bring these B cells back towards normalcy. On the T cell side, the memory T helper 1 and T helper 2 were reduced. And I had mentioned it, that reduction was as a result of the overstimulation. So we'll have to figure out how to normalize these T cells. Similarly, the cytotoxic T cells or CD8 positive T cells producing tumor necrosis factor alpha, they had increased and were exhausted as well. So that means they were overstimulated and then they got so much active by continuous presence of the antigen that finally they got exhausted. So how do we bring those cells back, or how do we just remove them and let the newer cells come in and perform better? Then the innate immune cells. There was an increase in non-classical monocytes, which are these monocytes patrol the cell boundaries, not the cell boundaries, the vascular boundaries, for example, blood-brain barrier, etc. And they were increased. That means there was going to be more inflammation in the immune privileged sites, for example, brain. And then the type 2 conventional dendritic cells were reduced. So we'll have to figure out how do we help these cells get back to normal. Then the cytokine alterations were present. For example, IL-7, IL-21 were different. Tumor necrosis factor alpha and IL-6 were dysregulated. Then there was, of course, the presence of the spike protein in some patients. There was EBV reactivation, and this should have been a bullet point here, which is separately present here, which is emerging autoantibodies like antinucleosome IgM and AQP4 IgA. These were indicators of autoimmune disease developing. So with this picture, what is the management approach? So I'm going to go section by section for the various managements that need to be done or interventions that are targeted at various pathologies. But here is a summary. We will try to reduce the inappropriate inflammation, restore immune regulatory balance. So one thing that was missing in the picture above, the T regulatory cells were reduced as well. So we need to restore the T regulatory cells so that they can then balance out the remaining immune system. So we have to restore the T regulatory cells, then we have to reduce the inflammation and also reduce the CD8 T cells. We have to support the clearance of spike protein in those individuals where it is still present. We have to prevent viral reactivation, or if the reactivation has occurred, we have to manage that. Then address emerging autoimmune features, so that IgM and AQP4 that were increasing antibodies, we need to figure out how to reduce them or how to manage that part of the B cell. Then we have to see how do we take care of the unswitched B cells. Either we kill them or we help them switch over to IgG and then move forward with their normal life cycle. We have to rebalance the innate arm. Remember, the neutrophils had increased in the recently infected, which is not a big deal. And then the non-classical monocytes and the dendritic cells had become altered. So we have to balance that innate arm as well. And then symptomatic management. So while the physician, the clinician is trying to fix these immune abnormalities, the patient is still suffering with various symptoms. So provide that symptomatic treatment as well, so patient can start becoming more functional as well. So that is the overview. So you could actually stop here, and if you're a physician, you could say, all right, I understand how to handle these points. I do not need to listen to the rest of it. But if you're interested, here is the rest of it. So inflammation modulation. In the vaccine injured and long COVID patient, both, the low-dose naltrexone works like magic. It modulates monocytes, microglial cells, it reduces tumor necrosis factor alpha, it reduces inflammation in the brain. It has just so many positive effects in these pathologies that low-dose naltrexone should be started as soon as possible. And I have done the discussions before that you can start with as low as 0.5 milligram per day and then double it and so on. There are some patients who would respond with side effects, for example, nightmares or other side effects, GIT issues. In that case, reduce the dose to half of what you're giving, wait for a week, and then start doubling again. And then you can double the dose every 1 or 2 weeks, eventually to reach 4.5 milligram per day and above. There have been doctors who have been prescribing even up to 11 milligram per day for the low dose naltrexone. I have seen very good efficacy within the 4.5 milligram per day range. But don't start with the 4.5 milligram, start with the smaller number, 0.75 milligram, and then escalate towards that over weeks and months. The other thing that is interesting about low dose naltrexone is that it doesn't start affecting the day you start taking it. It takes 6-7 weeks for it to then start working. So patient will complain for 6-7 weeks saying, this drug is doing nothing. And then all of a sudden, in majority of the patients, all of a sudden there'll be a switch that will go off and they'll come back and they say, I am magically feeling better. So this is a very interesting drug and should be added to all protocols. So again, we're talking about the inflammation modulation and immune suppression, mast cell stabilizers like chromalin, sodium, ketotifen, H1, H2 blockers, etc. So I have just put some over here. Short-term anti-inflammatory approaches. So for example, low dose steroids or other anti-inflammatory drugs like ibuprofen, etc., which are the cyclooxygenase blockers. Avoid prolonged use unless clear autoimmune evolution. So, of course, the steroids, we do not want to use them for a long time. And so either use the alternative therapies or maybe low dose steroids for longer time, depending upon the severity and the pathology. Then the targeted biologicals. For example, tocilizumab is the one, it's a monoclonal antibody that helps reduce interleukin-6. And similarly, infliximab is also a monoclonal antibody that reduces tumor necrosis factor alpha. So because these two were dysregulated in this specific situation, these drugs may be tried. Then section 3 is the restoring regulatory immune function. So remember, T regulatory system was abnormal, T helper cells were abnormal, B cells were abnormal, cytotoxic T cells were abnormal. So regulatory T cells, omega-3 fatty acids, and I've been preaching for this with due apology that omega-3 should be increased in the inflammatory states and omega-6 should be reduced. So omega-3, DHA and EPA should be increased. That would not only help reduce inflammation, but it also helps improve T regulatory cells function. So we need to improve T regulatory cells. So omega-3 is very, very important. Then vitamin D optimization. So vitamin D levels should be checked, and the vitamin D level should be above 30 as a standard protocol, but I've seen that above 50 nanogram are the best. Vitamin D also helps regulate and modulate inflammation and helps optimize all immune cells and their functions. Specific probiotics, for example, Clostridia, Bifidobacterium, or other bacteria which can be given for as a probiotic, can help regulate T regulatory cells as well. Then resveratrol, T regulatory expansion, and you would see that resveratrol can actually help on the spike protein side as well. So this would have multiple functions. So it also promotes T regulatory cell expansion and enhances immunoregulatory capacity. NAD is very, very important. It should be given just in general, but it does improve T cell metabolism as well. And then low dose IL-2 therapy. This is an experimental therapy where they give low doses of interleukin-2, and that can selectively approach the T regulatory cell and help them become better functional. Then is the supporting B cell maturation and class switching. So remember that the unswitched B cells were stuck in that state, so they've not switched over. Normally, what happens is that when B cells are stimulated, when they are activated, when they become plasma cell, they go from IgM production to IgG production to IgE and to IgA. They keep class switching. In this particular immune profile from the Yale study, the patients were stuck with the B cells that were in unswitched state for the spike protein. So such cells need to get out of that unswitched state, or these cells need to die away so that the newer cells can perform a more correct function, corrector function, if that is a word. So omega-3 fatty acids, they can improve the germinal center integrity. Remember, we discussed that it may be possible that during the vaccine injury, the lymph node germinal centers, that are small parts in the lymph node where various cells are being produced, maybe the germinal centers are defective because of the inflammation happening in the lymph node after the vaccination. And that damage needs to be reversed. And so omega-3s would help. How would they help? They would reduce the inflammation and they would allow the germinal centers rest so that the germinal center can start operating correctly and the class switching can start happening. One reason for the B cells to be stuck in the class unswitched state is that they're just working so much, they're producing so much antibody that they do not have the time and a chance to switch their class. So if you give them rest, they will then be able to hopefully switch their class and move on. Then vitamin D. As I said before, vitamin D helps all immune cells and actually all the rest of the body cells as well. So it is really important to have the vitamin D support. Then zinc is very important for B cell development and antibody class switching. So when we have unswitched cells stuck in that state, zinc can help either produce new cells that would class switch correctly or help class switch the ones that are stuck in that state. Interleukin 21 signaling. Interleukin 21 is critical for class switching. So when the B cells are class switching, there is interleukin 4, 5, and 21. They all have various effects on the class switching. So giving interleukin 21 could help B cell for class switching. So again, what we are trying to do is we are trying to get these B cells unstuck in this from the state they are stuck in. And not only they're stuck in that state, now they're making a lot of antibodies which are attacking the body or causing inflammation in the body. Then targeted immunomodulation, LDN. So LDN would reduce chronic inflammation, which will give rest to the immune system cells, which would allow the B cells to either die away or start doing the class switching, and hopefully more normal cells would be produced. Autoantibody reduction. So remember that we saw in this immune profile that IgM and IgA against the AQP4 were increased. So we'll have to figure out how do we start reducing these by either reducing the activity of B cell or by improving the B cell, as I'm showing here, or there may be other autoimmune therapies that will be needed. Then the viral reactivation, EBV was reactivated, correct? So then more EBV related therapies. I have just some points over here, but if you are someone who manages EBV, you would know better. So valcyclovir or famiclovir, these can be given. Monitor for the symptom flares of the EBV. Lysine supplementation is heard to be of benefit in herpesvirus. Monolaurin has been studied for antiviral properties. Quercetin and flavonoids have been studied for good immunomodulatory effect during the viral diseases. Immune enhancing adaptogens, for example, astragalus, and even ashwagandha is very, very useful. Ashwagandha doesn't directly affect the immune system, but it causes adaptogenesis, or you become more comfortable with whatever is the situation. That causes you to relax. And when you relax, the steroids, the adrenaline, the glucagon, which are stress hormones, they are reduced in their volume. And that also causes the immune system to get back on track and start functioning correctly. So immune support for viral control, in addition to antivirals, addressing the reduced memory T cells. Remember T helper 1 and 2. So long-term viral control has to be looked at. Then the persistent spike protein. And I have done so many videos about spike protein and its clearance. So just some ideas here. Spermidine, resveratrol, intermittent fasting, they all promote autophagy and spike clearance. Even a drug, lufimectin, may be able to help, which is a different name. You can ask someone. Extracorporeal therapies, for example, the blood plasma is brought out and then filtered and then brought back in, and hopefully some unnecessary immunoglobulins, and if there is spike, those can be filtered out. Double filtration plasmapheresis is also possible. Remove circulating spike and immune complexes, experimental. Then nattokinase or seraptase. These are proteolytic enzymes that may help break down protein aggregates, which is very important. NAC, and then other binding agents that can bind with spike protein, for example, pectin or chitosan or charcoal, etc. And I have done lots of discussion about spike protein. You probably are aware of the spike protein issues more than I am. Section 7, symptom-specific therapy. So this is the symptomatic therapy now. So various medicines that can help with the cardiovascular issues, with the POTS issues. For the POTS, there is IV saline as well. Then neuropathic pain management. This is very important. Low-dose naltrexone, alpha-lipoic acid, gabapentin, pregabalin are used. I would add fish oil here again, that the omega-3 is very good, fish oil is very good, vitamin A is very good, antioxidants are very good to help reduce the neuropathic pain. Magnesium is very important to help reduce neuropathic pain. Fatigue and mitochondrial support, so CoQ10, acetyl L-carnitine, nicotinamide, near infrared light. I have done this discussion before as well, better sleep as well. Then the cognitive function support. So phosphatidylserine, bacopa, lion's mane mushrooms, near infrared light, especially walk in the morning and evening when the sun is not overhead. That gives you near infrared light more than the red light. And the near infrared light can penetrate up to 4 inches in our body. And if you live in a colder environment where you're bundled up with the clothes, even then the near infrared light can penetrate through the clothes and help. Then mitochondrial support, anti-inflammatory polyphenols, for example, curcumin. Curcumin, I think, should be a must for everyone. And curcumin usually taken with some little bit of a warm milk. But if somebody is intolerant to milk, lactose, then curcumin with some ground pepper, black pepper. EGCG is very important. These address the tumor necrosis factor alpha induced mitochondrial dysfunction. Then quinones and pyrroloquinones, they stimulate mitochondrial biogenesis. Then you know that I've done this discussion before. Methylene blue can activate the mitochondrial complexes, especially complex 4 and 2. Near infrared can activate the mitochondrial electron transport chain complexes, especially the complex 4. Then sleep regulation, better sleep is very important. So melatonin, glycine, theta wave sleep. I have done this discussion in the past as well. Theta wave sleep is the best sleep for improving the cognitive decline. And theta wave is, sometimes you sleep so deeply that you get up and you say, man, this was the best sleep I had. Usually this theta wave sleep is, in children, majority of their sleep is theta wave. And as we start aging, the percentage of the theta wave sleep reduces. After 70 years of age, there is no theta wave. After 50 years of age, there is lesser theta wave, I think 25% only. So the theta wave sleep is necessary for healing of the neuron or cleaning of the neuron or reducing the inflammation there. And for that, it is important that we are so tired that we go to that deep sleep. So figure out ways to become tired enough that you have that deep sleep. Usually theta wave occurs when you go to sleep. Within 45 to 60 minutes after that, during the deep sleep, is when the theta waves occur. Then lifestyle and non-pharmacological approaches, for example, anti-inflammatory diets. Omega-3 is very important. Avoid histamine type diets, avoid omega-6 diets. Histamine diet, for example, eggplant or tomatoes or others, almost everything has histamine, but some big ones are tomatoes and eggplants. And have more green tea, more turmeric. Turmeric or curcumin is important. LDN is important. Vitamin D, zinc, magnesium, these are really important to keep in your protocol. Gradual movement. I had done this discussion before as well, that studies have shown that if the person does exertion, a lot of exertion during exercises, just to prove to themselves that, hey, I'm fine, they might end up causing enough damage to the muscles, which happens in all intense exercises, that those would further cause increase in inflammation. So long COVID patients and vaccine injury patients have to slowly start moving and then slowly increase their movement. Stress reduction is very important. Whenever we are stressed, either physically stressed or mentally stressed, we produce steroids and the adrenaline and glucagon and other hormones that actually cause inflammation, and they cause glucose increase, etc. So stress reduction is very important. HRV biofeedback, meditation, yoga, forest bathing, talking with your friends, whatever makes you happier. And then sleep optimization strategies, then time restricted eating or intermittent fasting. I believe intermittent fasting is really important if somebody is not nutritionally deficient already. And then environmental toxin reduction, the smoking cessation, alcohol cessation. If you are living in a polluted area, see if you can separate from that area for some time, etc. And then surveillance, quarterly labs for autoimmune diseases, then antibodies, the hormones. Remember, in this particular study, growth hormone and thyroid hormone, growth hormone had increased, thyroid had reduced, so keep an eye on them. Look at the organ system, especially look at diabetes and COPD, then cardiovascular health. Interventions, thresholds, just keep changing the interventions as necessary. And then if the specialists have to be considered, immunologists should be the first one to be able to profile the immune system. And then from there, the other specialists can come in. For the clotting risk, which this study did not have anything that would allude to that, but we know that the microclots are a problem. So D-dimer, should be looked at, fibrinogen should be looked at, bleeding time should be looked at. Then consider SARS-CoV-2 S1 protein microclot analysis, the low dose aspirin. This is very important, this area, to be discussed with your doctor, because this could cause bleeding and strokes or heart attacks, etc. So the whole thing should be discussed with the doctor, but here be very, very cautious. So low dose aspirin, then low dose DOACs, apixaban and rivaroxaban in higher risk patients, then antiplatelet alternatives like clopidogrel for patients with aspirin intolerance, fibrinolytic support for example, nitokinase or lumbrokinase, which are experimental, but many patients have said they feel better, and many doctors use them. Then supportive measures, hydration, movement strategies, compressions, garments. HBOT is another, which may be slightly on the expensive side, but also has been useful for some. Then advanced immunotherapies, IVIG therapy. Then other, for example, I would add that IVIG therapy, then the plasmapheresis, and then here rituximab, low dose IL-12 therapy, plasmapheresis, etc. So once again, for the clinicians, start with the simpler lifestyle changes, intermittent fasting, if the patient can do that, with the herbs and nutritional supplements first, food correction first, anti-inflammatory foods first, anti-inflammatory lifestyle first. then go to herbs and supplements, and then start with the allopathic medicines. However, low dose naltrexone is something that you can start from the day one. And secondly, doing a short steroid course to unmask any organ damage there or not, or to understand the intensity of the dysregulated immune system and its symptoms will be very interesting when you are starting this. So this is the discussion. I'm sure that I did not cover everything, but I think it is a good start for this specific immune dysregulation that you saw in this study. And with this, thank you very much. Please like, subscribe, and share. If you would like to support this work, there are links in the description for PayPal or for Buy Me a Coffee. And the best is if you can buy Drbeen. Over there, you can get CEs as well, CMEs as well. Plus, we do weekly Zoom calls too. You can join Patreon or Substack too. So thank you very much, and I would see you again.